Welcome everybody. My name is Jeroen Voorham. I'm one of the founders of the company and of the Maple itself. First, some meeting etiquettes. As said, the webinar will be recorded. Please mute yourself, and if you have any question, you can put them in the chat, and I'll try to, if I see something popping up, I'll try to answer either immediately or after, when there's a good moment to break in the story, so to say. And the recording will be available afterwards. So this is the shortly the agenda. So I will give a general introduction to EMG, bipolar versus unipolar. Then I will focus on a clinical study we did, bipolar probe versus unipolar probe with the Maple, done together with, amongst others, Doreen, who's also in the meeting. So nice to see. And if time permits, we could, because we only have 1 hour, I could quickly tell you a bit more about Maple protocols and guidelines, a dysfunction overview, and some cases. But again, if time permits. So a short disclosure. So I'm a former shareholder and current advisor of Novacare Pelvic Health BV. I'm a PhD candidate in my final leg of finalizing that in Leiden and the Antwerp University. And I'm not a pelvic floor therapist or a medical doctor. But I think in the course of years, I learned a few things about the pelvic floor. So of course, you know the pelvic floor anatomy, where you have all these muscles on the different sides and different depths of the pelvic floor, which are innervated by different nerves. The muscles in the lower parts by two branches of the nervus pudendus, and the muscles a bit higher up by two branches on the left and the right of the levator ani. So first, what is EMG? So EMG is from your nerve. There's coming electric signal from your brain through your nerves, and on the end of each motor nerve, there is a motor unit, and of the branches, and these motor units are stuck to one or more fibers in your muscles, and your muscle activity is muscle activity is captured during the depolarization of the muscle fiber, and that you can measure with EMG. The EMG, what you measure, is dependent, or if you say it in nice scientific words, EMG is the extracellular recording of bioelectrical activity generated by muscle fibers. And the EMG is dependent on the nerve, the muscle composition, the location of the electrodes, and the shape and the size of the electrodes. And it's also important to know that EMG is actually the difference in activity or in voltage. And there are two ways to do that, but I'll come to that shortly. So as you're all aware, the use of EMG in pelvic floor therapy is for biofeedback. This is the process of gaining awareness of many physiological functions, primarily using instruments that provide information on the activity of those same systems, with the goal of being able to manipulate them at will. And in this case, you use the EMG biofeedback to show which muscles, or to show the activity of the pelvic floor to the patient. And you also can do it as a diagnostic tool for the assessment of the muscle function. So the most commonly used method to measure EMG of musculoskeletal muscles is to use the bipolar approach. And here you have to place two electrodes in the length of the muscle fibers over the muscle, and then when you contract and relax, you see a very nice and characteristic EMG trace, so to say. It's important to know that it actually, the EMG is the difference of the signal measured at one electrode versus the other electrode. And with this, you can get a very good reading of this muscle, this specific muscle, from me. If you're going to use the same concept over multiple muscles, it is starting to get interesting. Let me put it like that. So when you put one electrode on one muscle and the other electrode on your other muscles, and you start, in this example, start moving your arms around, you will measure some electrical activity, but it's actually not EMG activity, because it are different muscles. They are innervated by different nerves. So actually, this is not a valid EMG, so to say. However, this is exactly how conventional bipolar probes work, right? This is a collection of the most commonly used and some more a bit more exotic. But what what these things all have is they have large either rings or plates, which cover multiple muscles on different depths, or on different depths in the case of the rings, or different sides. And as I said, for example, the green one is comparing the upper of the left electrode versus the right electrode. So the deeper layers of the pelvic floor versus the superficial layers of the pelvic floor, which again are primarily innervated by two different nerves. So yeah, what are you actually? What does that signal actually mean? What you're seeing? So the disadvantages of these probes are that they're not capable of measurement simulation, different depths or the different sides of the pelvic floor. They do not give information about the individual muscles. And as how we started, there was no scientific evidence on muscle activity of the healthy pelvic floor. And this is where the MAPLE came in. So MAPLE uses the unipolar principle. This means that the electrode, or all the electrodes, the activity there is the potential there is compared to a average reference one. And the nice thing about this technology is that it allows the comparison between muscles, but also the comparison between similar groups of healthy volunteers or patients. With MAPLE, we spend a lot of effort in determining the right reliability and differentiation of EMG signals measured with the MAPLE in healthy volunteers, but also in patients or doing sacral neuromodulation. Today, I'm only going to show the example of the healthy volunteers in this case. And what we did there in this clinical study is that we had 229 healthy volunteers, men and women. We gave them 5 tasks: rest, MVC, endurance, cough, and Valsalva. Excuse me. We measured the EMG values per electrode. We did a test-retest reliability in a small sample. But the first thing we actually did was a verification of electrical location in MRI in a small sample. So this is an example of a male on top and a female down, where we have the coronal view on the left and the sagittal view on the right, where you can, and the small arrows indicate where the muscles are. And here you can clearly see that on the different sides and different depths, the different muscle groups are located nearest to the individual electrodes, for men and for women. Without going into much detail, but what we saw is that the EMG activity of these in the closest to those individual muscles show differences in rest, maximum voluntary contraction, and endurance, which was more or less expected, because you expect that because it's EMG is dependent on muscle composition and the nerve innervating the muscle itself, that there are differences between those muscles even in rest, and that also that the activity during, for example, contraction of a muscle, that it increases, but also that there's still differences in the intensity of that EMG between the different muscle groups. Oh, yeah, and that's what, so this was the EMG goes from, for this example, for the puborectal muscle, goes from around 13 to up to 35 for MVC and endurance. You also see that those are we also looked at different groups. So these are 3 groups of women, where the darkest gray is nulliparous premenopausal, and then the middle one is Paris premenopausal, and the lightest gray is Paris postmenopausal. And what you see that actually from nulliparous to Paris, there's a significant drop in EMG activity of the activity nearest to the puborectal muscle, but also the bulbous bronchiosis ischiocavernosus muscle. There's a significant drop, which again, from a biological perspective, it does make sense, because there's it has, of course, giving birth has a impact on those muscles. As I said, we also did a test-retest, and that showed fair to excellent intra and inter-rater results. And this is more or less a summary of what I just told you. So what we could show, that there were significance in EMG values between individual muscles and between different tasks for the different groups. But we also saw that there were differences for the same muscles or the same locations for depending in which group the healthy volunteer was. So yeah, this has been published. If you're interested in it, we could share a link to the article with it. But this showed that the maple was reliable, that it's valid, that it can differentiate, and we had a healthy baseline established. One of the one of the challenges we ran into during this healthy study is that we were looking at the raw EMG signals. So that means if you think about how you do that with traditional bipolar systems, is that you're looking at one trace, but because the maple has 24 electrodes, looking at 24 traces at the same time and trying to figure out what is happening where is undoable, I know by firsthand. So what we came up with is that when you have the probe, also have one here. I'll not put it here because then it disappears, but I'll keep it here. You have the probe, and you can think a tunnel around it, which is either the vaginal wall or the anal canal, and then you have those different sides. You have bottom, top, left, and right. And if you could make that, you can flatten that view, and then you could push on the different depths and different sides. You can make some kind of what we call the maple grid. And the maple grid works more or less the same as with digital palpation. So at 12 o'clock you have anterior, left is at 3 o'clock, posterior is at 6 o'clock, and right is at 9 o'clock. And if you go from the outside rings to the inside of the grid, you move so higher up the probe or deeper into the vagina or the anal canal, which this animation shows you. So, and this will really give you the opportunity to see all the activity in one glance. And we use 2 scales. So we have the white to black scale, which is the absolute scale, which is white is no activity and the darker it gets to black, it will in the grayscale, it will be higher activity, so to say. And we also have the red, white, blue scale, where the system allows you to compare to the healthy reference group of your patient or your volunteer, where red is more activity, white is similar activity, and blue is less activity. If then you with this, how this grid works, and if you then think about the anatomy and the MRI images we shot, you could point out where, if there's no anatomical abnormalities, the different muscles are located in the grid. So again, if you have your probe like this, you have here to the left and right the bulbous, if it's a vaginal measurement, the bulbous spongiosum ischiocavernosus. If you go a bit deeper, you have the puborectal muscle, and deepest you have the ilio and pubococcygeal muscles. At the back you have the anal canal, and in the front you have the urethral sphincter positioned. Anally, you have in the smallest part to the exterior, you have the external anal sphincter, and this is the only probe which allows you to register all the four quadrants of the external anal sphincter in one go. And then if you go a bit deeper, you have the puborectal muscle, which makes a sling around the anal canal. And then deepest, you have the ilio and pubococcygeal muscles. And dependent on the gender, you have here, if it's a male, you have in front, you have the urethral sphincter and the urogenital diaphragm, or the vagina. So with this, you could see, or you get an idea which muscles function or not function on the different sides. On the different sides. So this is a bit of the general introduction around the maple, high over what the difference is in what EMG is, and also what the difference is in bipolar and unipolar from a I say physiological and technical perspective. I see that there are no questions in the chat, so I will just then continue with the research we performed, where we compared the bipolar a bipolar probe versus the unipolar maple probe. And I'll take a sip of water. So we used two probes to register the intervaginal EMG. The first one was a bipolar probe. I think you see on the left here. It's I think pretty commonly used probe, and it has a bipolar configuration, which gives a general intervaginal activity. You couldn't even call it EMG, in my opinion. And it has large electrodes, which makes it very sensitive to crosstalk. One of the things I mentioned briefly was that the larger the electrodes, the wider they can they can pick up EMG signals, and so also there's the risk that they pick up signals from the muscles surrounding the pelvic floor. And to the right, you have the maple, which is a reliable and valid unipolar 24 electrode EMG probe for registrations nearest to the individual pelvic floor muscles, and it has small electrodes, which makes it less sensitive to crosstalk. The hypothesis or aims of this part of this study was to describe the effect of contractions of the muscles surrounding the pelvic floor on the EMG activity of the pelvic floor muscles with a bipolar probe and a unipolar probe. We used 15 healthy pelvic floor therapists without complaints of micturition or defecation, sexual dysfunction, pelvic pain, or a history in pelvic surgery. The tasks we used which were compared for analysis was we did a 1 minute rest and 10 maximum voluntary contractions. And also we did some exercises to trigger contractions of various muscles surrounding the pelvic floor. Which we tried to target was the abductors, the adductors, the gluteal, the oblique, the rectus abdominis, and the transversus abdominis. In this slightly small table, you can see the instructions we were giving for the surrounding muscle contractions, right? We gave an instruction to push the right thigh outwards, and the resistance, because we used a resistance tool that they really had to push against it to also see that that every push or every movement was more or less in the same resistance range. So we get a consistent average, so to say. As I said, the push of the right thigh outwards, we try to target the abductors. And the position for this and the two to come was that the volunteer was lying on the back, headrest flat, with head on a pillow, with legs relaxed. Then we have the push of the thigh inwards, where the resistance was given in the inside of the right knee. And this was to primarily target the contraction, or to invoke a contraction of the adductors. We had to push the right heel down, where the resistance was given on the backside of the right heel to invoke a contraction of the gluteus. And in this case, the legs of the patient were flat on the table. Then we had bringing the right shoulder to the left hip without rotating the shoulder. We put the resistance here on the collarbone. This was to target the gluteus. The oblique. My apologies. The other instruction we gave was to put on a tight jeans. So really, try to squeeze your waist together so you could actually fit those tight jeans. The resistance was not applicable because there was no way where we could put our resistance tool, and this was to primarily target the transversus. And the last one we did was a slight curl up of the upper body, and we gave resistance to the sternum, so over here, and this was to target the rectus abdominis. And for the latter three, the position of the patients was with the head slightly bent, knee slightly bent, and legs flat on the treatment table. It's important to know that for all this, also the researcher, so the one doing the instructions with the patient, and all the participants, that they were blinded for the screen where the EMG activity was shown. This to prevent that there's unwanted learning curve, that when they see the EMG or the biofeedback, that they start reacting on it. So both for the researcher, but especially for the participants, as these were all trained pelvic floor therapists. So we wanted to be extra careful there. So for signal analysis and statistics, we took the average of the rest and the maximum voluntary contraction as a baseline for comparison of the activation of the pelvic floor muscle whilst executing the instructions. And now some fancy statistical words. We use linear mixed models to find out significant differences, and we set the statistical significance at smaller than 0.05 for the bipolar probe, and for the maple we divided that by 12 to end up with a 0.004167 for the maple to correct for multiple testing. So we were, we were extra firm or tough for the maple, to be sure that it wasn't an artifact of, because the idea behind multiple testing, if you repeat a test multiple times, which you could say, hey, you're more or less measuring in the same area, so you're kind of repeating the same test, and with correction for multiple testing, you say, hey, you have to decrease, or yeah, you have to decrease your when you can call it significant to correct for this. So to the results. I'm gonna sit straight. So the bipolar intervaginal activity this here you see the bipolar intervaginal activity caused by the surrounding muscles versus rest and MVC. So what we saw is that, yeah, on the right in light blue you see the rest. Can you see my, if I move my mouse, can you see that? I see Onno nodding yes. I see Doreen nodding no. So, okay. So perhaps not. So then I'll try to explain it in the words. So on the left side, the light blue, you see the rest one. And on the left, you see the MVC in red. The MVC activity was significantly larger than the rest activity. Which is expected, right? But what you also see that for for the different instructions, primarily targeting the key muscles surrounding the pelvic floor, you saw that for all the muscles, so the adductors, gluteal, abductors, rectus, oblique, and transversus, the activity was significantly higher than rest, but significantly lower than MVC. With pretty and the significances was below 0.02 for all, smaller than 0.02 for all these activities. So, but what does this tell you? That was the question. And how does this relate to when you see what you measure with the maple? So here you see the maple grid, where we had the rest and the MVC activity. The average the average rest activity was 3.0 microvolt. The average MVC activity was 9.07 microvolt, 9 microvolts, and also there in all the different size and depth there was a significant differences of smaller than 0.0001. So in line with what we measured with the bipolar probe. But now it gets interesting. So what you see here is for on the left side you see the absolute pelvic floor muscle activity, and then on the right side you see the difference normalized to the MVC. So what we did is we took the MVC as a baseline, so this picture, and we subtracted from that the activity, the absolute activity we measured during that contraction of the abductors. So, and the colors here mean white is their similar activity compared to MVC on that location, on that side, on that depth, compared to MVC. Blue means there's less activity, and red means there's more activity. And here you and I use there are 4 ways to mark all those fields where it shows where if you see a dash, it means that the activity was similar to rest activity. If you see the O, it was significantly higher than rest, but significantly lower than MVC. If you see nothing, if it's empty, then the activity was significantly higher than rest, but not significantly lower or higher than MVC. So then you can say it's similar to MVC. And if you see a plus, and that's combined with the red color, you see it is higher than MVC. So what you see here is when you contract the abductors, actually not the entire, so the outer parts of the pelvic floor have an EMG activity which is comparable to MVC. The middle parts have it's between rest and MVC, and the deeper parts, except for left, they show also are comparable to the MVC activity of the pelvic floor. For the transverses, you see a slightly different pattern. There you see that all the activity on the different sides and different depths of the pelvic floor is between rest and MVC, except left and right in the center part of the probe, where it's actually similar to rest. So what does that mean? That when we with the exercise to provoke a transversus contraction, which was the put on the tight jeans, there what you saw is that actually there was a partial contraction of the pelvic floor higher than rest but lower than MVC, but in the central side, or the center left right, there was actually no contraction, or because it was similar to rest. And the muscles which are located there, of the muscle which are located there on the left and right, is the puborectal muscle actually. So you can say that when you do this exercise, there's a partial contraction of all the pelvic floor muscles except the puborectal muscle. Now, so again, so what you see here in these two examples is that it gives you at least it gives you much more information than the bipolar alone, where it's just it's between rest and MVC, but actually there are more nuances to it, where part of the for the abductors there's actually muscles which are comparable to MVC, and for the transverses there's actually muscles who don't contract at all, or at all who show only a contraction but still comparable to rest. So now to the other muscle groups. So with the rectus contraction, it became actually quite interesting, because if you think about it, if people do a curl up, where they primarily contract their rectus abdominis, there's a lot of pressure coming on your pelvic floor. So you would expect that the pelvic floor responds to this. What we measured with the bipolar one was that the rectus abdominis was, again, the activity was between rest and MVC. So significantly higher than rest and significantly lower than MVC. If you look at the maple contractions, you actually see something different. Here, of course, you see that the absolute pelvic floor muscle activity is very high. And what you see is that it's the response of the pelvic floor in this case is actually, for all sides and depths, significantly higher than a maximum voluntary contraction. And this is, this is 100% opposite of what the bipolar probe told you with the intravaginal activity. So, and then we grouped the invoked contractions of the adductors, gluteal and oblique, where you saw that here the activity was, for all the sides and depths, was higher than rest, but significantly lower than MVC. So, what does this tell you? So the results of this study demonstrate clearly that all 6 different exercising, all 6 different exercises implying contractions of the various muscles surrounding the pelvic floor, and that contracting these surrounding muscles do affect the pelvic floor muscles. You see that the bipolar measurement does not reflect the actual activity of the pelvic floor muscles during the different exercises. And as a last, that there's There's a specific co-activation of the pelvic floor muscle, performing abdominal exercises for the abductors, transversus, rectus, and other surrounding muscles, that this perhaps could be utilized in combination with or as a replacement of conventional pelvic floor muscle therapy. Example given when you use palpation, when EMG or biofeedback or electrical stimulation is not possible. And of course, as with all research, there's this standard disclaimer at the end that, of course, more research is needed to further elaborate on this topic. But I think the results where you see that the bipolar one gives you a very generic overview, and that when you see what you measure with the maple, that it gives you much more information and it's much more specific, and that it's also more specific, and that there are actually that there are nuances in difference which muscles contract or don't contract depending on the specific exercise you're doing. So, are there any questions so far? Remarks, challenges? You can put them in the chat. Then I can, let's see if there are people typing. No. Okay, nice. Oh, I see a hand from Doreen. That's also possible. You can also raise your hand if you have a question. So Doreen, you can unmute yourself and ask your question.
Yes, I want to. Can you show the last slide?
This one or this one?
No, not this one. I have a little doubt. No, the next one.
Yeah.
Of your last conclusion, because I doubt if you can use the muscles to train the pelvic floor, because the problem with EMG is you never know what kind of contraction it is. If it's a concentric, eccentric, or isometric contraction. So I doubt if that's advice.
So perhaps I phrased it a bit, or we phrased it a bit crudely, but what I'm trying to say there is that when, for example, there's no direct contraction of the pelvic floor muscles possible for whatever reason, because patients don't know, etc. Perhaps you could use this, I said, because this is one of the hypotheses is that because you contract your muscles surrounding the pelvic floor, there is a feedback loop which causes your individual pelvic floor muscles to correct, right? Which is not coming from the brain, but coming from your spine. So perhaps then, if patients don't have the direct link from the brain to the pelvic floor muscles again, perhaps you could utilize these exercises to get at least a partial contraction of the pelvic floor muscles. But again, this is a hypothesis that we developed, which of course needs to be tested further. But how we had some discussion about how we could do it, but we're up till now we didn't proceed with it, and it's also sometimes a bit difficult to really measure contraction of specific pelvic floor muscles versus specific muscles, for example, by nerve blockages or needle stimulation of nerves that could be of surrounding muscles, then to see the response. But this is all, we didn't put that into a real research yet. But that will perhaps even give more insights in how these mechanisms work.
Yeah, thank you.
Okay. So yeah, looking at the time, because we still have 20 minutes left. So what then I supposed to do? I'll shortly tell you something about the MAPLE protocols and guidelines, and then I think there's some I could spend the last 10 minutes or so on showing some typical EMG activity which can be related to specific complaints. So this is an overview of all the Maple protocols we have. So we have a protocol for the assessment of the pelvic floor muscles, where we have written down, I think, more or less, we've written down the protocol which we used in all our studies, from the healthy volunteer study up till the study we did with this study we did with the pelvic floor therapists, but also the protocol we used in our study where we studied women with OAB. We have a few protocols regarding how to actually interpret what you see. We have the grid explained. We have the location of the muscles, and we have the 6 questions and a small cheat sheet. And for therapy, and with we, I mostly mean experienced pelvic floor therapist, and also together with Doreen, we wrote down if you see something in the grid, what can you do with it, depending on what you are trying to achieve, and that's for biofeedback as well as for electrical stimulation. So the Maple assessment protocol is essentially it's pretty straightforward, right? It's just the resting part is just a 1 minute rest. Important there is that you that you actually do not interact with the patient, because sometimes if you start talking, the patient starts responding to that or looking to you, and that could interfere with your measurement. So with rest, it's important to just really, I said, be quiet for 1 minute. Especially when you do the assessment. I think when you're in training, it's a bit less important, but when you do the assessment, it's actually, you need to be strict on that, in my opinion. It is 10 maximum voluntary contractions in 3 seconds, where you ask the patient to try or to contract only the pelvic floor muscles, not the rectus abdominis or using the legs, etc. That they contract, relax in that cadence. And in the protocol itself, we also scripted how you should give those instructions. Same for 3 endurance contractions of 30 seconds, where you say them to contract and hold that contraction, and also a first concept for 2 Valsalvas of 5 seconds. Here, it is very important that the patient is blinded for the screen. That is because the beauty of biofeedback is that if you see something happening on the screen, some patients really almost immediately start reacting on what they see to see if they can influence us, which is a good thing, because that's exactly the purpose of biofeedback, that they see what's happening and try to I should influence what's happening. But for the assessment, it is absolutely necessary that the patient is blinded for the screen to get an objective measurement of the current status of the pelvic floor muscles for those 4 activities. So here you see an example of how an actual Maple measurement look like, where you have on the right side you have a line graph which shows a couple of things. This is the average EMG activity of all the 24 electrodes, and in this case, this was the contraction exercise, where the gray zones and the green lights the green lines indicate where they should try to contract, because the system will help you then to when they do it in those periods to actually calculate the average activity during that MVC. And then what you see on the left side is the Maple grid with the activity on the different sides on different depths at that specific moment in time live. And when the your assessment is done. It gives an average overview of, for example, the 10 MVCs of the rest or of the 3 endurance contractions or whatever you put into the system. So that is how to see the grid. And as I said, there are 2 scales. You have the gray scale from white till black, where white is no activity and black is high activity. And as said, you have the blue, white, red scale, where blue is less activity than the healthy reference group. White is comparable to the healthy reference group, and red is higher than the reference group. For all measurements, we no. Let me tell you. Let me put it differently. So the question we often get is how do I? There's a lot of things going on, and do you have a standardized approach on how to interpret what I'm seeing? So what we developed was what we call the 6 maple questions. So for during each measurement, you ask yourself and you evaluate, what do I see in the graph? What do I see in the grid? And where do I see it in the grid? And depending on what measurement you are doing or what assessment you're doing, what is the relation with the other assessments? So how is my rest related to my MVC and vice versa? And the same for endurance to rest or to Valsalva, whatever. And after finalizing your assessment, there are 2 more questions, which are the sometimes the bit tougher ones. Is how can I link what I've observed to the complaints of this specific patients? And then when you figure that out, so which muscle function I want to improve, because this dictates what your options, what your best options will be, or your first options will be, for example, for biofeedback exercises or for electrical stimulation. And it's important to know that, of course, there's not one right way to exactly do number 6. So which muscle function I want to improve. There are multiple ways or multiple angles you can go for to see if that helps for this individual patient, because it's not a plug and play standard standard device where you put it on a standard program and you walk away for 20 minutes and then you come back and the patient is helped. No, it's really an individual program. I don't know if I've seen this a couple of times in a specific region in Europe where there were like 4 or 5 chambers next to each other, and the pelvic floor therapist was going from one chamber to another. It looked like some kind of a pelvic floor factory, which I found very interesting approach, because I really believe the contact and the context the pelvic floor therapist gives during these exercises and during biofeedback and electrical stimulation is really invaluable, in my opinion. So, and of course, these Maple protocols and all those, the guidelines are available, and you could ask for them to either Ono or to your local distributor, and we will be happy to supply them to you, and if needed, to provide more context around how to use them. And then, again, if there are any questions, please raise your hand or raise them in the chat. If not, I will spend the last couple of minutes to quickly give what I call the dysfunction overview. And again, it's important to know that this is not, there's not one, there's not one grid where you could say immediately from the grid, oh, this is this dysfunction, this is stress, or this is urge incontinence. No, it is really independent on the individual patient, where you really have to see which muscles function or do not function. Yeah, so there's not one, so how I say it, there's not one grid telling you, the grid itself will not tell you what it is. It's always the combination with what are the complaints, what do I see in the grid, and then to try to help your patients, which muscle function I want to improve. I see there's a question from Samantha Arnoul. Does stimulation help with anismus, and if so, how? I think that question is best answered by Doreen. If you can unmute yourself. Just a little explanation. So Doreen is a Maple user from the first hour, and she is very in the Dutch in the Dutch and international field. She's renowned or known for her electrical stimulation knowledge. So please, Doreen, can you help me answer this question?
Can you repeat the question?
So if for how can electrical stimulation work for anismus?
Yeah, it depends on the complaints of the patients and what you found with EMG. If the examination of the EMG shows you an overactivity of parts of the pelvic floor, you can try to influence them with a low frequency for pain, and that's the 2 hertz. And then you get twitch contractions, and you get a reflex of relaxation. That's one thing. So if it's really a kind of activity with gives a cramp, then you can do that. And when it's pain on the complaint is pain, then you can try the 100 hertz. And if you have your examination of the EMG, you can put the electrodes on the localization of the overactivity.
Yeah, so you could really say, if, for example, the overactivity is...
If you do the 2 hertz, you take the parts of the overactivity. And if it's pain, you are going to try the locations, and you ask the patient if he recognizes the location of the pain. So there are 2 different things. If you want to do the overactivity, you take the parts with the high activity and you take 2 hertz. And if you want to have influence on the pain, you have to ask the patient if he recognized the place of the electrical stimulation.
Oh, she's saying a little off topic, but thank you. No, I think it was actually, and also I think you're touching an interesting point there, is that if for example you don't see anything strange in your EMG activity, but they still feel pain or something else, it could also be when there's no abnormal activity, or you see no overactivity, let me put it like that, in rest. It could also be that, for example, there's something else going on because of the when there's, for example, I don't know if that's the case with anismus, but if there's the complaint of tightness, it could be that it's the ligaments, for example, of the muscles, or the other parts of the pelvic floor which are actually causing which are causing this. So I said even no EMG activity will guide you towards where you could best start your your treatment or your therapy.
Yes, I agree. So if you have pain and you don't measure high activity, stretch the muscle.
Yeah.
But when you want to treat pain, you also can influence the sensible nerves with 100 hertz.
Yeah.
That's a different way. And then it doesn't matter if you have a high tone or not, overactivity or not, you can treat pain with 100 Hz.
Yeah.
Yeah, okay.
Thanks, Doreen. So then quickly, just as I said, there's not one type of grid which shows you a specific dysfunction or complaint. So this is an example of 4 cases where all female where they suffered from stress urinary incontinence, and on the left you see what the activity was at rest. In this case, for this specific case, at rest before the treatment and after the treatment, where there was a I will keep it in control if you're okay with that. Where you see the resting activity has evened out. Here you see a lot of local overactivity during in rest, and then after therapy, which was, I think, primarily electrical stimulation combined with relaxation exercises. You see a clear difference that I said that the EMG activity has evened out. Also here you see with endurance that there's the the problem of difficulty to release, and then again there was the same complaint, stress urinary incontinence, but the focus of the therapy was somewhere different. Here it was relaxation in rest, so relaxation, and here it was more relaxation after contraction. So same indication, different therapy approach. Did I hear it right? Okay. Let's go. There's another question in the chat. Did I hear this right? Pain complaints and no overactivity, manual stretching of the pelvic floor. Yes, that could be one of the first options you can try then. Yes, to see if that decreases the pain. Right, Doreen? Oh, yes.
Yes, you can read the articles of Melanie Morin. She write about it. Melanie Morin.
So I've put her surname. Oh yeah, I think it's Mourin with OU. Let me quickly double check that. Oh no, with sorry, you. Where's mine? It's over there. Like this in the chat. Yeah, so looking at the time, we're at time. So I want to thank all the the audience for being there and listening, and for the interaction and the questions. And as said, we will the recording will be available afterwards. And if there are any more questions, remarks, etc., happy to you could either you could email us and send it to us, and we'll try to follow up. So with this, I want to